All right. So our urinary system, fairly simplistic system compared to several other systems we've seen so far this semester, especially just thinking about our last system that we covered, which was the digestive system. You had a whole bunch of different organs. When it comes to the urinary system, it's just 6 organs. You got 2 kidneys, 2 ureters, a bladder, and a urethra. So 2, 2, 1, and 1 makes 6, if my math is correct. As far as those organs go, we're going to spend the majority of our time talking about the kidneys because they are classified as like the true, or not necessarily the true, but the major urinary organs. Okay, and they are going to serve the most complex roles. Okay, I kind of broke it down their functions into kind of 2 categories. Those that fall in here under maintaining homeostasis, and then those that are involved with non-waste elimination and recycling processes. With regards to maintaining homeostasis, our kidneys help rid the body of wastes and recycle necessary elements. So waste products could be simple like water. For example, if we have too much water, we need to get that out. And in fact, water is a major component of our urine, which is what our kidneys form. Along with that water are other waste products like urea, uric acid, and whatnot. And then when it comes to recycling things, sometimes we want to conserve water. If we are dehydrated, we don't want to be peeing out the little bit of water that we have. So we would recycle that along with other necessary things for our body. With regards to non-waste elimination recycling processes, our kidneys help maintain our blood volume, which refers to the amount of blood that we have. And if you think back to when we talked about blood, we learned that blood was about half water. And so essentially, by either conserving or peeing out more water, that's going to affect our blood plasma, which therefore affects our blood volume. Okay, that's going to help regulate blood pressure in itself. And the kidneys also release a chemical called renin that is going to be part of a really complex cascade of events that will elevate your blood pressure. So that's a way that the kidneys can also regulate blood pressure. Kidneys help maintain normal blood composition. So what's in the blood? So, keeping the percentages of plasma and the stuff in the plasma compared to the formed elements and all that wonderful stuff we talked about here a few weeks ago, keeping those things in check. Maintaining normal body and blood pH. That's very, very important. Your kidneys, along with your lungs, are the most important organs that help regulate our body's body and blood pH. And then 2 hormones are released by the kidneys: calcitriol, which is involved with calcium homeostasis, and then erythropoietin, which is what we use to make our red blood cells. That's the hormone that stimulates the production of red blood cells. Okay. With regards to everything else, it's just either a tube or a sac that holds urine. Okay. In the case of the ureters, those are tubes or conduits that transport urine from our kidneys to the bladder. And then the bladder, which we can see right here in our illustration, is going to store that urine and waste until it's convenient to be disposed. When it is convenient, we expel our urine out through the urethra, which discharges the urine to the outside of the body. And we can see that short tube right here in our illustration. Now, in this picture, we can see some female reproductive organs, which tells you right away that this is a female, which includes the uterus that you can see here, the ovaries, the fallopian tubes. Men are obviously not going to have those same structures. But they do have all those same urinary structures: 2 kidneys, 2 ureters, a bladder, and a urethra. When it comes to the urethra, this is going to be one of the rare instances that we've seen this semester where there's a very big difference between males and females. So far we've talked a lot about basically organs being pretty much the same. When you talk about like the kidneys in a male and a female, they're basically the same size, located in the same place. Sometimes organs are a little bit bigger, like we think about like the heart of a male is typically a little bit bigger than in females. Bones and muscles are bigger in males than typically in females. here's where we're going to see some big differences, which will be a nice transition into our next lecture, where we see extremely big differences. As far as what I want you to know from this image, it's not, a crazy important image, but there are those 6 organs. It's essentially just everything that's already capitalized for you. So the right kidney, the right ureter, urinary bladder, the urethra, and then over on the left side of the abdomen down there, you have the left kidney and the left ureter that I want you to know. Some of those things you also can see include like the adrenal glands that we've talked about before, the renal veins, renal arteries that we kind of mentioned back when we talked about blood vessels. We see the aorta and the inferior vena cava and whatnot, but those aren't really anything I'm worried about, because those aren't necessarily urinary related. All right, like I said, we're going to start by talking about our kidneys, and we will continue to do that for the majority of the lecture. Just those 3 blanks, it looks like. Okay. All right, we'll start just by kind of talking about the kidneys as a whole. They're kind of just overall gross anatomy. There are a pair of them, and they are both reddish kidney bean shaped organs located just above our waist. We classify them as being retroperitoneal, which we talked about that phrase or that term the other day, which means that they lie posterior to the peritoneum in our abdominal cavity. So they have that shiny membrane covering them. They lie to the right and left of our spinal column and are protected by our 11th and 12th ribs, but also by the thick back muscles that are, like our latissimus dorsi muscles that are pretty thick and protective in their own right. But that's not always 100% efficient. In boxing and like MMA fighting, if you were to hit somebody in the lower back, they call that a kidney shot for a reason. The kidneys can be damaged by direct blows to the lower back, which can be very dangerous, obviously. Right kidney, if you didn't notice it on the previous page, it's just a little bit lower than the left kidney, and that's because, and hopefully you remember, that right lobe of our liver occupies a big space right in this area that I'm highlighting there with my cursor. Okay. Typical size of a kidney is about 10 to 12 centimeters or 4 to 5 inches in length, 5 to 7 centimeters or 2 to 3 inches in width, and then 3 centimeters or about an inch in thickness. Each one generally weighs about 4.5 to 5 ounces, so they're pretty small, both in size and in weight. Each kidney is surrounded by 3 layers of tissue: the renal or fibrous capsule, which is the innermost, so that's the deepest layer; the adipose or perirenal fat capsule, which is in the middle; and then the renal fascia, which is on the outside. It's the superficial layer. Looking at the illustration here at the bottom, in the picture of the cadaver on the right, or the cadaver kidney on the right, we can only see one of those 3 layers, and that's that renal capsule, and that's that thin layer here you can see labeled down there at the bottom. Okay. Let's talk a little bit about that. The renal or fibrous capsule is, once again, the inner fibrous membrane of dense, irregular connective tissue, continuous with the outer coat of our ureters, functioning as a barrier against trauma and helping maintain the shape of our kidneys. Deep to that is the adipose, or once again, perirenal fat capsule. Obviously, hence its name, it is made up of fatty tissue. It surrounds the renal capsule and protects the kidneys from trauma and holds them in place within the abdominal cavity. So this is kind of a cushioning layer. Fat can cushion very well, and that's what this layer does. And then surrounding that is the layer of renal fascia, which is thin superficial layer of dense irregular connective tissue, anchoring the kidneys and those adrenal glands to surrounding structures on the abdominal wall. On the anterior surface of the kidneys, it is deep to the peritoneum. If I jump ahead to the next page, I didn't include this on your lecture because it's really not a great image in my opinion. It's really kind of hard to tell what's what. But this is basically a transverse section, so the body's been cut in half horizontally, and you can see where the kidneys are. Surrounding them are those 3 layers, and about the only view to have all 3 layers visible would be this one. But like I said, not one I'm worried about you knowing. You can kind of see them here in this bottom image, which is a sagittal section where the body's been cut from front to back, and those are labeled, but I'm not even going to really worry too much about those because, like I said, not the best images. So those are the kind of outer protective structures associated with the kidneys. Moving into the interior of a kidney, you'll find what we call the renal parenchyma. There's a word we've seen a couple different times this semester. Parenchyma refers to the glandular tissue forming the urine. So this is the functional part of our kidneys, and is divided into 2 zones, the renal cortex and the renal medulla. The renal cortex is the superficial light red region, and you can see it labeled here in our real cadaver image, but it's a lot easier to kind of tell it apart over here in our animated version. Okay, it's kind of this light tan shaded region on the outside, and we know that's what the word cortex means, towards the outside of an organ, whereas the renal medulla is the kind of darker brown middle part of the organ. Okay, if you notice though, there are extensions that are lightly tan colored on the interior of the organ, just like there are those lightly tanned regions on the outside of the organ. Those extensions here between the kind of triangular shaped parts of the medulla are called renal columns. Okay, and so those are extensions of the cortex that project towards the center of the kidney. Okay, and that's something that's visible and will be definitely something I want you to know for the exam. Cortex actually can be divided into a superficial cortical zone and a deep juxtamedullary zone, but those are so small and minuscule that they aren't illustrated in the picture. Okay. Now, as I said, the renal medulla, shown here in the kind of darker brown, is kind of broken up by those renal columns, and that creates these kind of triangular shaped or fan shaped regions, okay, which are called renal pyramids. And you can see why I would call them renal pyramids. They have that triangular shape, just like a pyramid does. Each pyramid consists of a base, which is what faces the renal cortex, and then an apex, which is called the renal papilla, that joins or points towards the renal hilum. Okay, so this would be the base, and then down here, where it comes to a point, would be the renal papilla, which you can see is labeled in this image right there. Okay, we'll talk about the renal hilum here in just a second. Okay, let's first talk about a renal lobe. A renal lobe consists of a renal pyramid, its overlying area of renal cortex, and 1/2 of each adjacent renal column. So essentially, it's very nicely shown here with the kind of dark black line. It's got one pyramid, the cortex surrounding that, and then 1/2 of a column on each side. So that creates a renal lobe. That's just kind of the functional unit of the kidneys, and you can see, probably going to be around 6 to 10 of those in the kidney, because there's about 6 to 10 of those renal pyramids. Okay. Now, within both the medulla and the cortex of a kidney are nephrons, which are the really most important part of the kidneys, because those are the microscopic filtering structures that form the urine. Okay. Each kidney contains about 1 million of these, and they're very small, microscopic. They've done a good job here in this illustration of showing you one of them. They've just highlighted it here in yellow. They always kind of use yellow for nephrons, which is probably because they're the ones that make the urine, and urine has that kind of typical yellow coloration. But you're going to find about 1 million of those throughout our kidneys. Okay? When those nephrons form the urine, it is going to flow out of the nephrons in a specific pattern from those renal pyramids. Okay? First, it's going to travel into what we call papillary ducts, which you can see are basically at the bottom of the nephron. Okay, we'll talk about the structures of a nephron, which include a collecting duct here in a little bit. From the papillary duct, the urine will flow into what are called minor calyces, or minor calyx for one. Calyces is plural. Okay, that's what these little cup-like extensions that come down from the renal pyramid are. Several of those merge and form a larger cup-like structure called the major calyx. Okay, and there's multiple of those, so that's why I have major calyces listed up here. Those converge again and form what's called a renal pelvis, which is just a continuation of the ureter, the tube that drains the urine out of the kidneys. Okay, and then from there, the urine will then drain to the urinary bladder, as you can see, their little path of urine drainage listed on the right. Okay, each kidney has a hilum, or renal hilum, as it's labeled here in this picture. An indentation near the center of the concave border where the kidney receives renal nerves, blood vessels, lymphatic vessels, and a ureter. It's essentially the same thing as what we've seen several times here lately. Remember, our lungs have a hilum. So does, things like your lymph nodes, your spleen had a hilum. Okay, just an indented part of an organ. Okay, and this hilum expands into a cavity within the kidney called the renal sinus, which is something that's labeled right here in our picture. Okay, as far as this picture goes, it's a very, very important image. There's a very, very good chance you will see it on the exam. I would say pretty much any and everything would be fair game for the exam, with the exception, I probably wouldn't worry too much about identifying the renal artery versus renal vein. It's pretty easy to tell when you have it in red and blue, but as you guys have your printout, it's not in color, so they're going to show up gray, and that's how they'd probably show up on the exam. So I wouldn't worry too much about being able to identify those two from one another. Sound good? So make sure you know these things labeled here on the left, plus, be able to identify the path there and all those things that are labeled. The only thing that's not labeled that's listed there would be the bladder, because you can't see it. But that's okay, not a big deal. We'll talk about the bladder later on. So that's the kind of just overall arching anatomy of a kidney. Let's talk about its blood flow. Something we talked a little bit about back when we talked about blood vessels were the renal arteries. And in fact, those were one of the few things I colored in our very first picture that we colored in that lecture, coming off of the abdominal aorta, for a couple of reasons. And that included the fact that those were like the only organs that were still down there in the abdomen. But I also colored them in because of the amount of blood that travels through those to feed our kidneys. Even though your kidneys only account for 0.4% of your overall body weight, they receive about 21% of your blood pumped by the heart per minute during resting conditions. So right now, as you're sitting here listening to me talk, as I'm sitting here talking, about 21% of your blood is going to those very small organs. Okay? And delivering that blood to those two organs are the renal arteries, which you can see back on that picture, and I talked a little bit about them at that point. And we can also see one of them here, since we've got one kidney, and this will be the right renal artery, since this is a right kidney, and they come directly off of the abdominal aorta. Okay, just before or after entering the hilum, each renal artery then divides into some smaller, what we call segmental arteries. Okay, and those are the blood vessels that penetrate to the interior of the kidney. Okay. And then those give rise to what we call interlobar arteries. We call them interlobar because, as you guys remember, hopefully by now, I've said this a million different times this semester, inter means between. And so interlobar means between lobes, okay, or between lobes, okay? And that's what they do. They travel between each renal pyramid, where then they again branch into what we call arcuate arteries and then several interlobular or cortical radiate arteries. And those are what pass upward into the cortex. And at this point, we're going to get very, very small. So I'm going to kind of zoom in and walk you through it. So we've got our segmental arteries coming in. They then branch, and those form the interlobar arteries, which are traveling through the lobes. Okay, remember, a lobe is one of those pyramids, half of a column, and then the cortex on the outside, and that's what it's doing. It's traveling through the columns. And from there, then you form arcuate arteries, which then branch and form cortical radiate arteries, which, as you can see above, cortical radiate arteries also go by interlobular, which I'm guessing they've kind of tried to go away from because it's really confusing when you have interlobar and interlobular, and those words sound very similar. But I wanted to make sure you know that that's also a term that you'll see for these cortical radiate arteries. As those interlobular or cortical radiate, whatever you want to call them, artery, ascends through the cortex, it branches into a series of afferent arterioles, which turn into a mass of capillaries called a glomerulus, which then leaves the capsule as an efferent arteriole. Now, these are very, very important. We're going to talk more about afferent arterioles, glomerulus, and efferent arterioles, because those are all associated with a nephron. Okay, they're the blood vessels that are going to provide the very first filtering processes in the formation of urine. Okay, the afferent arteriole brings the blood into the nephron, which then inside of this ball-like structure, that afferent arteriole divides and forms a capillary network called a glomerulus. And this is where we're going to start pulling stuff out of the blood and start the formation of urine. Okay, it's not going to be urine at that point, but it'll be called filtrate, which is the precursor to urine. What's not pulled out of the blood will become what's called an efferent arteriole, okay, and that will flow out of that capsule, and we'll get into more about that here in a little bit. Okay, it leads to what we call a plexus of peritubular capillaries, which pick up water and solutes reabsorbed from renal tubules, and these things are going to make a lot more sense here in just a little bit when we get to the nephron slide, and that's coming up just shortly. Okay. Eventually those capillaries drain into interlobular or cortical radiate veins and so on, and eventually, you know, the blood will travel out of the kidneys by way of the renal veins, which are going to be the veins that carry the blood back to our inferior vena cavas. And it's just the same pathway as with arteries, except it's all in reverse. So it goes from interlobular to arcuate to interlobar, okay, and then eventually you get to the renal veins. Okay. Now, in between the renal arteries and the renal veins, you'll also find a specialized network of blood vessels called vasa recta, which are associated with what's called the loop of Henle. And like the afferent arteriole, glomerulus, we're going to see and talk a little bit more about that in a little bit. And picture over on the right is showing you just how much vascularization there is within your kidneys. This is from a cadaver. What they've done is they've injected a special chemical into their arteries and veins. Obviously, you can see red and blue, and it's a coloring dye, but it also hardens. And once hardened, then they were able to essentially dissolve all the glandular material of the kidneys to leave just where those blood vessels originally were. And pretty much every square little segment of that kidney here is vascularized, demonstrating once again just how much blood is going to be able to flow through the kidneys, about 21% during our resting conditions of our blood goes to those kidneys. Now, as far as identification and whatnot, you don't need to worry about this picture. I do recommend, though, that you kind of be able to follow the flow chart. So maybe put a star, or highlight this box here, or this step-by-step path of blood flow. I may or may not ask you to do that on the exam. Maybe I wouldn't do it completely, but I might, you know, ask you From where does blood flow after it leaves an arterial artery? And you'd want to make sure you know cortical radiate arteries, or maybe I'll put a few of them and I'll tell you to, make sure you know the order. Now, keep in mind, you see cortical radiate artery, cortical radiate veins. Might not be a bad idea to put in parentheses their other name, just in case I ask you to know that, which is interlobular. So here, cortical radiate arteries, once again, are interlobular arteries. Cortical radiate veins are also known as interlobular veins. Sound good? All right, so let's talk about those nephrons, which will make a lot of that make a lot more sense. Once again, each kidney contains about 1 million of these, a little over, and I say a little, I mean 1.2 million. That's significantly a good number of nephrons, which both of our kidneys, or all of our nephrons, I should say, contain two principal parts: a renal corpuscle, which is what we'll talk more about on this page, and then on the next page, which I'm actually jumping ahead, is the renal tubule, a long winding tubule, which there's several parts to that, and we'll get into all of that. But let's first talk about the renal corpuscle, which is where we filter our blood plasma and form the precursor to urine, what we call filtrate. It's comprised of that afferent arteriole, the glomerulus, and the efferent arteriole, which are the blood vessels that we were just talking about on the previous page. Okay. Essentially, what we have is, for the corpuscle, this portion of the nephron, which they've done a fairly simplistic illustration of a nephron here. And here we are basically just zooming in and looking at those parts much more in detail. Let's first talk about the afferent arteriole. This is the blood vessel that delivers the blood to the nephron. Okay. It will then turn into a mass of capillaries called a glomerulus. Okay. And in our illustration here, we can very easily tell the afferent arteriole because it's a nice red tube. It's a arteriole, obviously, so it's an artery and it's colored red. The capillary network, known as the glomerulus, is harder to kind of see, but it's inside of this kind of yellow stuff. Okay, and that yellow stuff is a bunch of cells. These cells are called podocytes. To me, always look like little bugs with little legs that wrap around the capillaries. So the capillaries, and you can kind of see if you look hard enough, little red in between those little legs of those podocytes, okay, are inside. Okay. What those podocytes do is they wrap around the capillaries and they act kind of like a coffee filter. If you want to think of them like a coffee filter, their job is to allow certain things through, but not the big things. When you make coffee, you put your grounds in the filter, and your little collecting part of the coffee maker. Then you pour the water through, and the water goes through the filter just fine, but the grounds hopefully do not, so you're not chewing on your coffee. Okay. These podocytes, which have little leg-like features called pedicels, prevent the big stuff from leaving the blood. Okay. Things like our red blood cells, our white blood cells, our platelets, our plasma proteins should not be leaving the blood. If you have any of those things in your urine, something's not correct. Okay. Looking kind of here at the bottom of the page, we've zoomed in and shown how those podocytes are wrapping around the blood vessels. Okay. Notice that these little finger-like extensions are not completely fluid tight. They have little gaps, and those little gaps allow for the big stuff, or the little stuff, excuse me, not the big stuff, but the little stuff to leave the blood. Okay. But what we see here is that the wall of the capillary is fenestrated. Remember, we talked about the 3 different types of capillaries a few weeks ago. We learned that some capillaries have tiny little pores or holes in them called fenestrations. Okay. And that's what these capillaries have. So they're super, super leaky. Okay. think of them like a strainer that you know, when you're making mac and cheese, like we make a lot in our house, that allow you to move stuff easily through them, but not everything. When you pour your boiling noodles and the water into the strainer, the colander, whatever you want to call it, the water passes through those holes very easily, but the noodles do not. And the noodles are too big. They don't fit through the holes. And that's like what your blood cells are like. Okay. So not only do those finger-like extensions from the podocytes prevent the big stuff from going through, these holes are not going to allow those big things to travel through either. You're also going to find some membranes, okay, especially this filtration slit. The slit membrane, as it's called, is going to prevent medium-sized proteins, as you can see, from traveling through. So basically, we're able to allow a lot of stuff that's really small to exit, which then allows it to enter into this capsular space. Okay, the inside of the what we call glomerular capsule or Bowman's capsule, which is the entire structure. We've got it open here, but it's this kind of ball-like structure with the capillaries on the inside that collects the filtrate, which would be out in here, and then pushes it out into the beginning of our renal tubule and the first segment, what we call the proximal convoluted tubule, which we'll talk more about here in just a second. Okay. Now, like I said, not everything is going to leave the blood. So what's going to be retained in the blood is going to exit out of the capsule into the efferent arteriole or via the efferent arteriole. Okay. So blood comes on in via the afferent. We filter it. We pull a lot of stuff out, forming filtrate, precursor to urine. We don't pull everything out, and what's left in the blood leaves via the efferent arteriole. Make sense? Okay, I do want you to know a couple of things from this image. Highlight the afferent arteriole, highlight the parietal layer of the capsule, highlight the capsular space, highlight the proximal convoluted tubule, even though it's not technically part of the structure, but I do want you to know it nonetheless. Highlight the podocyte that's labeled. I'm not going to worry about the pedicel. That's the little foot or finger-like extension. Kind of harder to tell what's the foot, what's the cell. So just the podocyte's fine. And then the efferent arteriole. Now, if I jump ahead to the next page, here's a microscopic view of a corpuscle. You can see the glomerulus labeled there. You can see the podocytes wrapping around the blood vessels, which is the glomerulus, the capsular space. So it is a lot of blood vessels and a lot of cells, and not as quite as open as you can see here. That's going to enable the stuff to come out of the blood, and then eventually it's going to drain out into the proximal convoluted tubule, which is not labeled in the image, but it would be probably right there is my guess. Okay, over on the left side, we can see labeled things like the efferent glomerular arteriole, which is the same thing as the efferent arteriole. That's the blood vessel that drains the blood out. Okay. Over here is the afferent, which is the one that's bringing the blood in. Okay, which is pretty cool to see. Nothing you need to really worry about. This is a really cool picture, in my opinion. It's showing you the interior of a corpuscle zoomed in 150 times. It kind of looks like a little brain, but it just really demonstrates just how long and winding that capillary network really is inside of the capsule, which has been opened up. Okay. Here's a really cool picture, probably the coolest picture in my opinion, showing you microscopic view of those podocytes wrapping around the capillaries. You can see their little finger-like extensions wrapping around and once again preventing the big stuff from leaving the blood and only allowing the water and the small stuff out. So that's pretty cool, but nothing I'm going to worry about. Obviously, you don't have those pictures, so you don't need to worry either. All right, let's talk now about the long winding, what we call renal tubule. this is where that filtrate will go. And eventually, as a result of moving it through the long winding tubule, we will have converted that filtrate into urine. And so that's essentially the function of this long winding renal tubule. Now, as we move that filtrate through the long winding renal tubule, we're going to pass stuff back and forth between the blood. So we haven't officially called it urine for a reason, because it's truly not at this point. Once it's into what's called the collecting duct, we can pretty much call it urine, but it's not quite urine until it's to that point. Okay? So reading through renal tubules, a winding hollow tube extending from the corpuscle to the end of the nephron, where it joins the collecting duct, which is shared in common with other nearby nephrons. We can call our renal tubule the urine collecting and concentrating tube, and is divided into 3 regions, beginning with the proximal convoluted tubule is what sometimes you'll just see it as listed as the proximal tubule, which if I go back to this picture, that's how it's listed. I really like that they call it a convoluted tubule. If you don't know that word, you might have heard that word before. We see it again here for the distal convoluted tubule. It means basically kind of like a jumbled up mess. It's not a straight tube by any means, but instead it's kind of a zigzag type tube. Okay. Notice that the proximal convoluted tubule, which is shown here in yellow, is surrounded by a whole bunch of blood vessels, which are those peritubular capillaries that you see labeled right here. And what we're going to do right after we formed a lot of filtrate here by filtering our blood and pulling it out into the capsular space, we're going to end up giving most of that water back. It sounds really weird, but we're pulling gallons and gallons and gallons of water out of our blood a day. Thankfully, we're not peeing gallons and gallons and gallons and gallons of urine a day, okay? Which means once we've pulled that stuff out of the blood, we have to put it right back, okay? And those capillaries are going to readily accept that stuff right back. That process is called reabsorption. And we talked a lot about absorption in our digestive lecture. That was where, for example, like when we drink water, it makes its way into your stomach, your small and your large intestines, and then we pass it through those organs and into the bloodstream. That was the first time that water had entered our blood. Okay. Well, now we're pulling stuff out of the blood into the nephron, but then we're going to put it back. So you're returning it. Okay. And that's why we call it reabsorption. Okay. The opposite of that is secretion, which secretion is where you're pushing stuff from the blood into the tubule. So that stuff that's secreted becomes a component of the filtrate and eventually will be urine. Okay. Now, the reason that we are able to do so much reabsorption and secretion in our renal tubules is because the cells here have lots and lots of mitochondria, which gives them a lot of energy. Okay. But also their cells will be simple cuboidal in shape and in layer number. Simple tells you that there's only one layer. But most importantly, the cells have a prominent microvillus. Prominent, and I can actually just show you very nicely, feature where they have those little finger-like extensions, making that cell surface, the surface that faces the interior of the tubule, its surface area is very, very enhanced. It's just like what we saw in the small intestine with those absorptive cells. Okay, the more surface area, the more ability to contact the stuff that's in the tubule and return it back to the blood. Okay. Now, in the next segment of the nephron, we have what we call the loop of Henle or nephron loop, which is a long U-shaped segment of the tube. Okay. This part of the tube dips down from the cortex, which is where everything that we've talked about so far is, down into the medulla. Okay. And so it's going down more to the center of the kidney. and is divided into kind of two segments, a descending limb and an ascending limb. Okay, the descending limb comes down, ascending goes up. Okay, now it's not super easy to see, but if I look over here on the right with this different type of juxtamedullary nephron, you can see that in some places the loop of Henle is really, really thin, whereas in other places like right here, it's a lot thicker. Okay, well, that's important because that's related to what's moving and in which direction. Okay, the cells of the loop of Henle can vary from simple squamous epithelium, which means that there's only one layer of flat clay-like cells. In other places, you'll find simple cuboidal, okay, which means there's got one layer and the cells are cube-shaped. And then some places you'll even find simple columnar, which means one layer and they're tall column-shaped cells. Okay. In all those cells, though, typically you're going to find that they lack microvilli, those little finger-like extensions that you found in the cells of the PCT. Okay. The thicker segments of the loop have simple cuboidal epithelium and are engaged in active transporting salts and therefore need extra mitochondria for ATP production, which is what makes those cells thick. Okay. The thin segments of the loop have simple squamous epithelium and are very permeable to water, which means water is easily going to travel through those thin segments, whereas in the thicker segments, we're not moving water, but instead we're pumping salts. Okay. And they actually say if you were to like taste a kidney, like even like lick the interior of a kidney down in its middle parts, it's going to taste pretty salty because of that pumping of the salt that's taking place in there. Okay. Once again, the two limbs are known as the descending limb, which passes from the cortex and the medulla. The thin segment that suddenly narrows as it descends. The ascending limb is a portion of the loop that turns 100 degrees, returns to the cortex, and contains a thick segment that widens the tube as it passes upward. Okay. So from the ascending limb, we come back out into the cortex, where we then see the tubule jumble up again, which is why we call this the distal convoluted tubule, or as it's just labeled here as the distal tubule. Okay. This is our last segment of our nephron, which then conducts the filtrate out of the nephron and into a collecting duct. Okay. Associated with this distal convoluted tubule is what we call the juxtaglomerular apparatus, which is a portion of the distal convoluted tubule that brushes right past that afferent arteriole that we talked about on the previous page. And this interaction helps maintain the homeostasis of blood flow. Okay. If I zoom in at this picture, look what's happening right here as I circle it with my little hand. Okay. The distal convoluted tubule is coming right back, and they actually basically touch one another. It's touching this afferent arteriole, which remember is the blood vessel that's bringing the blood into the nephron at the beginning. Okay. What this enables for is communication to occur between the cells of the distal convoluted tubule and cells of the afferent arteriole. And basically this can control how fast and how much blood is coming in, which therefore affects how much filtrate we form. It's a protective mechanism that would like prevent too much stuff from being filtered out of our blood, and therefore we lose too much like water or whatever it is in our urine. Okay. If I were to go back, which I'm going to, this picture here, I didn't mention it at the time, but here we can see that juxtaglomerular apparatus. Okay, here's the afferent arteriole bringing blood in. These cells here called juxtaglomerular cells are basically touching, and you can see, and I say basically, they really are touching these cells called macula densa. They communicate with one another. I don't know really why it says ascending limb. It really should be the distal convoluted tubule, but this is that distal convoluted tubule where the filtrate is now flowing. And for example, if we're forming way too much filtrate, these cells are going to tell these cells to kind of cause this afferent arteriole to pinch. Okay, so less blood comes in, and then that's going to slow down the formation of filtrate. Okay. We call it a juxtaglomerular apparatus. If you've ever heard the word juxtapose, it means like right next to, like it's a term you hear in like art or in like photography. If things are juxtaposed, they're right next to one another. In this case, it's the the distal convoluted tubule, and the afferent arteriole. Okay. From the distal convoluted tubule, that filtrate is going to flow out into what's called a collecting duct. Okay. And a collecting duct is formed by the joining of distal convoluted tubules from several nephrons. Okay. So in other words, a collecting duct is not singularly associated with one nephron. If we look here, notice these little branches shown here. We can see another couple down here. They're just cut off. It's not like these are dead ends. There'd be a whole other nephron attached there and there and there. So a collecting duct is shared between several nephrons. Okay. And we call them collecting ducts because that's essentially what it's going to do. It's going to collect the filtrate and finalize and form the urine from it. Okay. Within the collecting duct are cells that are going to be cuboidal with few microvilli. Okay. And from the collecting ducts, at this point we can call it urine, will drain into what we call papillary ducts, which then drain into the minor calyces of the renal pelvis through the medullary papillae or papilla, which we talked about a couple of slides ago. Two types of cells present in the collecting duct and the actually final portions of the distal convoluted tubule. They include principal cells, which respond to hormones aldosterone and antidiuretic hormone. And those are hormones that help regulate the kind of processes involved with urine formation that I'm not going to get into in this class. And then there's also intercalated cells that secrete hydrogen ions that help us control our blood's pH. Okay. In other words, that helps us pee out urine or pee out acids, which is what helps regulate your body's pH. Now, there are two types of nephrons that exist, and you can see they are down here at the bottom. On the left is a cortical nephron, and a juxtamedullary nephron is on the right. The majority of our nephrons are this type, the cortical nephrons, that make up 85% of the nephrons in our kidneys. And they're called cortical because most of the nephron is out in the cortex. Remember, cortical is just, I think, the adjective version of cortex. Okay. And so the loop of Henle is the only part, and it just barely dips down before coming right back up and into the cortex from the medulla. Whereas juxtamedullary nephrons, which make up the other 15%, have a much, much longer loop of Henle that dips way, way down deeper into the medulla. And as a result, it makes a more concentrated form of urine. And those are the ones that are going to have those special blood vessels I mentioned a couple of slides ago called vasa recta, which surround the loop of Henle. As far as these two pictures go, you don't really necessarily need to worry about them. But if I jump ahead to the next page, we have just a blown up version of a cortical nephron with stuff that I'm definitely going to want you to know. Okay. So here's what you need to highlight. On the left side, make sure you highlight both the proximal convoluted tubule and the peritubular capillaries. Okay. On the right, starting on the top there, you can skip the first one, but I want you to know that we're in a corpuscle as a whole, but also make sure you know the capsule in the glomerulus. The capsule is the outside structure. The blood vessels inside is the glomerulus. Highlight the efferent arteriole, which actually efferent, I think is spelled incorrectly there. There should be two F's. That's okay. Highlight the distal convoluted tubule, the afferent arteriole. I would also, it's not labeled, I would draw a circle like I'm doing right now with my cursor. Draw a circle like that and label that as that juxtaglomerular apparatus. Which is once again that connection between the DCT, the distal convoluted tubule, and the afferent arteriole. Okay, jumping down from there, we already said afferent arteriole. You can skip from there just down to the nephron loop. And, it might not be a bad idea, put in parentheses loop of Henle, because that's what it's also known as. Make sure you know the descending and the ascending limbs. Know the collecting duct, the papillary duct, renal papilla, and the minor calyx at the bottom. Make sure you also can tell that this is a cortical nephron. Maybe I'll just put the picture on the page and say what type of nephron this is. So I guess, you know, if you go back to this previous page, make sure you can just identify cortical versus juxtamedullary, which hopefully isn't too difficult to do. Sound good? So at this point, we finally finished talking about the kidneys and can talk about the other organs of the urinary system, which includes the pair of ureters, two ureters that are connected to our two kidneys that carry the urine down to our bladder. We'll talk about the bladder at the bottom of the page. And then we'll have on our last slide the urethra to discuss. All right, your renal pelvis attached to your kidneys, going to funnel the urine into our ureters. Our ureters can be described as muscular tubes passing posterior to the bladder and actually entering it from below. So your bladder actually fills up from the bottom because that's where the ureters connect to your bladder. We'll see that at the bottom in our picture. They exit each kidney at the renal hilum, of course, downward in the retroperitoneum, just like your kidneys are behind your peritoneal. Each ureter consists of 3 layers of tissue: an inner mucosa, middle muscularis, and an outer adventitia. There's a lot of similarities that actually exist between your ureters and your esophagus. Okay, remember the esophagus is the tube that carries food to our stomach. Okay, your ureters have an inner mucosa, so does your esophagus. Okay, your esophagus had a middle muscularis, so too does your ureters. Okay, let's talk about those different layers. Inner mucosa is going to secrete mucus to help protect the ureter tissue from urine, which is slightly acidic. It's composed of a mucous membrane with transitional epithelium and an underlying layer of lamina propria, which is areolar connective tissue. If you don't remember, we did talk about transitional epithelium at the very beginning of the semester when I first talked about tissues. If you think back to that point, we talked about the fact that some types of epithelium, the cells can change their shape, where they can be cube shaped and then kind of squished down and become more squamous. That's what transitional epithelium is able to do. And that enables essentially the mucosa to kind of flatten out, which opens up the interior of your ureters a little bit more. The middle layer is the muscularis layer, made up of longitudinal and circular layers of smooth muscle. It's going to help force urine forward by peristalsis, which is just like what we saw happening in our digestive system, including our esophagus. Remember, peristalsis, like squeezing a toothpaste tube from the backside towards the cap. So that's what gets the urine hopefully down into the bladder. The outer layer of the ureter is the adventitia layer, made up of areolar connective tissue with nerves, blood vessels, and lymphatic vessels. The bladder is a lot like the stomach in that it is a sac made up of a lot of muscle and can hold our urine just like our stomach can hold food. But this muscular sac is on the floor of our pelvic cavity, sitting inferior to the peritoneum and posterior to pubic symphysis, which, if you remember, the pubic symphysis is that little piece of cartilage between your 2 hip bones. In males, it's located in front of the rectum, and in females, it's located in front of the uterus. So here's where we kind of see some differences. The openings in the bladderal wall from the ureters, there are 2 of them. We call those urethral openings. There's a third opening that leads to the urethra, which we call the internal urethral orifice. Okay. So the urethral openings, literally the word ureter begins that word. That will be handy to kind of use to help you remember. This is where the urine comes into the bladder from our ureters. And then on the bottom of the bladder is the opening that leads to the urethra. what we call the internal urethral orifice, which is not to be confused with the external urethral orifice, which is where the pee goes out of our body. Okay. Now, if you draw a set of lines between those three openings in your bladder, you create a triangle, and that triangle has a special name called the trizone. That happens to also be a very common place where you see bladder infections. It's just a smooth surface triangular area on the bladder floor. Just like the ureters, the bladder contains 3 layers of tissue, an inner mucosa, which is a mucous membrane, very similar to that of the ureters, except it has a special feature that our ureters do not have, what we call rugae, or mucosal folds, which are folds in the mucosa that permit expansion. You can see they are labeled here. And another great example of the similarities between the bladder and the stomach, because as we previously learned, your stomach also has those rugae. Middle layer of the bladder is the muscularis layer. Although it has a special name, it is called the detrusor muscle and is made up of 3 layers of smooth muscle, and inner longitudinal, a middle circular, and outer longitudinal. And that's very similar to the stomach, which also had 3 layers. Around the opening to the urethra, the circular fibers form what's called the internal urethral sphincter, not the orifice. The orifice is the opening. The sphincter, which we talked a lot about sphincters in our digestive lecture, is a structure that essentially is going to allow urine through or prevent urine to go through. Okay, we'll talk a little bit more about the internal and the external urethral sphincter on the next page, because those are more associated with the urethra. Speaking of the external urethral sphincter, it is a modification of the deep muscles of perineum. And the perineum is your bladder floor, or not your bladder floor, but your pelvic floor. The most superficial coat on the posterior and inferior surfaces is the adventitia, which is a layer of areolar connective tissue continuous with the ureters. But over the superior surface is the serosa, which is a layer of peritoneum, a visceral peritoneum specifically. And so we can see that it's not labeled as serosa or visceral peritoneum, it's just labeled as peritoneum, but we can see it there nonetheless. Now this is a illustration, actually this would be a female, I can tell you that for a variety of reasons. I mean, mainly it's the size of the urethra, which we'll be talking more about here in just a second. As far as this image, I do want you to know it, and I would say pretty much everything would be fair game, with the exception you don't need to worry about the hip bone that's labeled, because that really has nothing to do with what we're talking about. All right, let's talk about the urethra. Final organ of the urinary system. Its job is to transfer urine out of the body in a process known as micturition. Micturition, fancy word for peeing. Okay, we've seen a lot of fancy words for kind of simple things. For example, mastication, which sounds a lot like micturition. Don't confuse those, because mastication is chewing. Very different, obviously, than peeing. But this is the tube that exits the bladder and drains urine to what we call the external urethral orifice, which is just fancy word for the exterior opening of the body, what commonly people will call their pee hole. Okay. In both males and females, the urethra is the terminal portion of the urinary system and the passageway for discharging urine from the body. Okay, but here's a big difference. In males, it also discharges semen, so it's a common structure for the urinary and reproductive systems, which we'll be talking again about that on our next lecture. And let's kind of go through each of the urethras, the male first and then the female. The male urethra extends from the internal urethral orifice to the exterior while passing through kind of 3 parts. And so it's broken down through to 3 divisions. The first division, as it passes through the prostate gland, a gland that's reproductive in function. As it passes through this, we call it the prostatic urethra. This is the one that can be a big hang up, especially in older guys, as it's fairly common for the prostate to kind of enlarge, which is going to kind of close up that portion of the urethra and make it more difficult to urinate. It's harder to kind of keep a steady stream, and that's pretty darn common in older guys. And now from there, as the urethra passes through the perineum, the floor of our pelvic cavity, we'll call it at that point the intermediate urethra, or also will be called the membranous urethra. The longest segment of the urethra, though, as it passes through the penis, is called the spongy urethra. And it's called the spongy because it's passing through the spongy tissue of the penis, which, like I said, we'll talk more about that in our next lecture. Okay. This total distance is about 20 centimeters or 8 inches. Okay. So very, very long, whereas you'll see here in a second, I'll just mention it, the female urethra is only about 1.5 inches or 4 centimeters in length. So much, much longer in men than it is in women. Okay. 2 layers make up the male urethra, a deep mucosa and a superficial muscularis. Muscularis of the prostatic urethra is composed mostly of circular smooth muscle fibers, superficial to its lamina propria. And these are the fibers that help form the internal urethral sphincter that I pointed out on the previous page. The muscularis of the intermediate urethra consists of circularly arranged skeletal muscle fibers of the deep perineal muscles that help form an external urethral sphincter. Several glands and other structures deliver their contents into the male urethra, which will be discussed in our next lecture, which include things like the prostate that I mentioned and whatnot. Okay. Female urethra, once again, very short, only about 4 centimeters or 1.5 inches in length. Strictly urinary in function. The external urethral orifice is located between the clitoris and the vaginal opening. The wall of a female urethra consists of a deep mucosa and a superficial muscularis. Mucosa is a mucous membrane composed of epithelium and lamina propria. Muscularis is made up of circularly arranged smooth muscle fibers and is continuous with the urinary bladder. Now, in both males and females, the urethra is guarded by 2 urethral sphincters, and it's a very similar situation to what we just talked about the other day with the 2 anal sphincters. There's an internal and then there's an external, and it's the same situation where the internal is involuntarily controlled, and that is because it's made up of smooth muscle fibers, whereas the external is voluntarily controlled, and that's because it's made up of skeletal muscle fibers. Okay. Down here at the bottom, I kind of pointed more things out here in the male picture, but we also over on the right have a female picture, which gives you a good view of the urethra, whereas it's a totally separate structure from the reproductive structure in females known as the vagina. These 2 pictures, I'm not going to tell you anything to highlight quite yet, because, and I say quite yet, we're going to see those 2 images again in our next lecture. This male picture, for example, is going to have a lot more added to it when we throw in all the reproductive structures. So, you know, it doesn't make a whole lot of sense to highlight stuff and then turn around and highlight them again, plus other stuff. So we'll just kind of wait on that. And kind of the same thing, we won't add as many things to this picture in the reproductive lecture, because you can see things like the vagina and the uterus are already labeled. But things like the ovary that's visible, the fallopian tube that's visible aren't labeled. So you'll see some new stuff in there in our next lecture, but we'll just worry about that when we get to that point. I do think it's a good idea, though, to put a big old star, highlight this box down at the bottom, which is going to talk about and show some differences between the male and female urethra. It's about 5 times longer in males than in females. There's 3 segments in male urethras, whereas there's only 1 short tube. It's just the urethra in females. And in females, it's a completely urinary functioning organ, whereas in males, it's a reproductive and urinary functioning organ. Sound good? Any questions?